This conference will now be recorded.
All right. Yeah.
Okay.
I just want to go over a couple of things real quick. So some people may or may not have seen a change in their grade over the last week. The reason why is because up until this point, all the pretests that you have not completed have been basically just sitting in a void in the system, and there was no grade associated with them. So I had to go in and zero any pretests that weren't completed out, and that affects your grade. If you're not here on Saturdays, that affects your grade because once I go in and zero those out, it affects your grade. So from here forward, I'm putting it out there now. It's going to be recorded now. If you do not complete your pretest by the due date without ample amount of notice, I will zero it out. You get a week to get it done. If you don't do it, I don't feel bad. I'm going to zero it out. If you are in a situation where you're out of town or you're on vacation and you need an extension and you request that ahead of time, then that is something that I'm willing to work with. If you tell me that I've been at work all week and I haven't been able to get it done, suck it up, Buttercup. I don't know. I mean, you get a week and it takes like an hour. I don't think anybody in here takes those pre-tests more than like 30 minutes. I can see how long it takes you to take them. And there's very, very few people that take longer than like 30 minutes to do it. If you can't find 30 minutes in a week to complete it, then we're just going to zero it out. As far as the regular test goes, if you know that you have missed a regular test up until this point, this is your one freebie. Because I've said like 30 times, if you need an extension on your test or if you need to do your test outside of normal class hours, to let me know. And I will open it up for you to take it. There are about six people or 6 different test assignments that people have missed class for that haven't been completed. I don't know if everybody can see it, but I imagine the ones that have not completed those assignments can see them. So I have opened them up for the next 2 weeks. You will have until 2 weeks from today, which is April 15th, to complete those tests that you have missed. If they are not completed by then, you will get a 0. I will zero them out. So, just so you're aware, I am going in. I'm not looking at it anymore. I'm not trying to contact folks. I feel like we're 2 months into this, and I've said it enough that I'm tired of talking about it. So I'm just going in, and I can click a big button at the top that says manage all incomplete assignments. And I can click that, and then it tells me 0. And then I'm just going to hit 0. I don't care who did it, who didn't do it. If you didn't tell me about it before that day, then I'm just going to zero it out. Like I said, if you need a extension on something, then come talk to me. But if you don't talk to me and you just don't do it, then I'm just going to put a 0 on it, and we're just going to wrap that up as a loss. Remember, you signed a agreement to maintain an 85 or better average. So if your average, we've been giving grace down to an 80. If your average drops below that because of incomplete assignments, you will no longer be a part of this class. So please finish your assignments, because I don't want to kick a good student or I don't want to kick somebody that's getting stuff out of class just because they get too busy to be able to finish the little minuscule stuff. Like I said, it takes 30 minutes to go through those little pre-tests. If you can't find an hour out of your week to do that, and then you can't find 30 seconds out of your week to text me and explain why you didn't do it, then I guess you just didn't want it done and you wanted a 0. Clear? I feel like that's pretty self-explanatory. As far as the Saturday hours go, everybody that has missed a Saturday class has gotten a 0 to this point. If you so choose to come back to me and make up those 8 hours, then I can go in and change that grade later. I will not do that for the pretest. That's over with. Wrap it up. It's done. Toss it in the trash. But if you choose to come make up hours at a later date, then I can go back in there and change those grades. But as far as the pretest goes, if you don't do it from this point forward, then I'm just going to put a 0 on it. We're just going to wrap it up as that. So that's the reason why. If anybody's seen a drop in their grade over the last week, that's the reason why. It's because I went in there and updated all of those grades. So, yeah, clear as mud. If you so choose to drop this class, you have until April 4th to drop this class. If you drop this class after April 4th, which is what, Thursday, Friday, then you get none of your money back. For the people that aren't paying for it, obviously they don't really care. But for the people that are paying out of pocket for it, if you're going to drop now or forever hold your pockets, because now that money's ours. Clear? Sound good? Anything else? Test. All right. Everybody open up their test. 28, 29, 30. I think because of all the issues that I've had with these pre-tests, I'm just going to start testing people on this stuff beforehand to see how much offline studying you're doing. And I guess we'll see how much you're doing in your free time. If you're not doing it in your free time, then we'll find out real quick. I got to find the password. Oh. Don't forget to stop the recording on that too.
Okay.
This conference will now
Yeah,
be recorded.
It
Trauma.
Trauma.
Big trauma drama.
So just so y'all are aware, Thursday, I'm just going to say this because I feel like this needs to be said just out of respect for the individual. Calvin will be here Thursday. We're going to talk about Calvin's situation and Calvin's story. We have permission for him to be here. He has given us permission to talk about him and the situation that happened involved in him. There's a lot of things that we have to keep in mind is that Calvin is a human. Accidents happen. Stuff happens. Be respectful of him while he's here. All right. Don't, please, for the love of everything holy, don't hit him with a bunch of like inappropriate questions. I know everybody's favorite question is, what's the worst call you've ever seen? Stuff like that, especially with him, just because this is still fairly fresh with him. He talks about what he can and what he feels comfortable talking about. We're not going to sit here and inundate him with, how did you feel? What happened? What do you think about when you go to sleep at night? Stuff like that. So I just want to say that while he's not here, so that whenever he gets here Thursday, we're all very respectful of him and what happened to him, because he does or is allowing us to talk about what happened to him, which is a fantastic, absolutely beautiful way to showcase the capabilities of a 911 service, from the sheriff's department to the EMS to the hospital and everything that went into making sure that he got to come back home alive, because there's a lot of places that he lives in this country, he don't come back home alive. So I felt like that needed to be said ahead of time before he gets here. So just keep that in mind come Thursday while he's here.
Okay, is everybody ready? So we're going to do 29 and 30 today. 29 is on bleeding and shock. So we're going to start talking about the circulatory system. So what are the three main components of the circulatory system? Heart, blood vessels, and blood. Right. Okay, good. So the heart, that's our pump, right? We should all be pretty familiar with the heart at this point. Its function is to pump blood throughout the body. It has to beat at an adequate rate and rhythm. We have the blood vessels, which are the pipes. So as far as blood vessels go, we have arteries. What do the arteries carry? Oxygenated or deoxygenated blood? Oxygenated. Okay, unless it's going to the lungs, right? The pulmonary artery and the pulmonary vein are opposite, right? But all other arteries in the body carry oxygenated blood away from the heart. Are they under high or low pressure? High. So when we take a blood pressure, that's what we're measuring, is their arterial pressure, right? So then we have the capillaries. So those are the microscopic little tiny blood vessels that are between arteries and veins. They feed our skin, all of our organs, everything in our body are fed by these capillaries. So they assist with capillary exchange of oxygen, nutrients, and waste. So cells, when they have cellular waste, that diffuses through the capillary to go back to the heart. And then oxygen comes from the blood through the capillaries and into the cells to use. So that's that capillary wall permeability. They have high permeability. And then there's veins. So blood that's depleted of oxygen and loaded with CO2 is carried back to the heart through the veins. So veins also have one-way valves that prevent the backflow of blood through the circulatory system. And they also have less pressure than arteries. And then we have our blood, which is the fluid. Ooh. So our blood has lots of different functions. It transports gases. So what are some of the gases that our blood transports? Oxygen, CO2, yeah. So diffusion of these gases occurs at the alveoli in the lungs and in the body cells. So we just kind of talked about that. Blood plays into nutrition. So it carries nutrients from the intestines or stored tissues like fatty tissue, liver, muscle cells, and other body cells, or to the other body cells, excuse me. It helps with excretion. So it carries waste products from the cells to the excretory organs, which would be what? What are our excretory organs? What's one example of them? Kidneys, right? Blood also assists with protection of the body. So it carries antibodies and white blood cells, which fight disease and infection. It carries platelets and clotting factors that help control bleeding and form blood clots. And then blood also assists with body regulations, that homeostasis. It carries hormones, water, salt, enzymes, and chemicals that help maintain homeostasis and helps regulate the body temperature. All three of these components have to work together to maintain perfusion in the body. What is perfusion? Okay. So what is another word for hypoperfusion? Shock. Good. Okay. So this is kind of what that looks like, a better way to visualize it. So this is coming from the heart. We've got our oxygenated blood going through the arteries. The capillaries are in the middle of those arteries and veins, and then the veins go back to the heart with deoxygenated blood after that oxygen is used by the cells in the body. So this is another little picture. The arteries are highly muscular because they have a lot of force and pressure in them, right? There's the capillaries, really tiny, small vessels. They're, I think, made up of only one layer of endothelial cells. And then there's your vein on the other side, and it shows that one-way valve. So shock. Okay. 4 overarching categories of shock. So we can have a volume problem, which would be hypovolemia. We can have a pump problem, which would be cardiogenic shock. We can have a blood vessel tone problem, which is distributive shock. And then we can have obstruction of blood flow, which is obstructive shock. So those are like the 4 overarching categories of shock. There's different kinds of shock, like anaphylactic shock, septic shock, all those good things, but they fall underneath these 4 main categories of shock. So next is just like a really quick 2-minute video kind of describing these different categories of shock, and then we'll go into it a little further in a minute. What's wrong?
For some reason that isn't going on with me.
Okay. That's all right. How can I get board like on my PowerPoint?
Have it run screen with share.
Okay. So I wanted to write on this, but I don't think I'm going to be able to. So anyways, so we have the overarching title of shock, right? So what would be our 4 different main categories of shock that we just talked about? Okay. 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 Good. Okay. So for hypovolemic shock, that means there's insufficient volume, like insufficient fluid, right, in the pipes. So what would be some things that could cause hypovolemic shock? Dehydration. What else? Blood loss. What did you say? Sepsis. That could be, but that's not typically like the main category we'd put sepsis in. But yeah, so blood loss, internal or external hemorrhage, and that's also known as hemorrhagic shock, right? So blood loss equals hemorrhagic shock. Dehydration. Another one is burns, actually, because you lose a lot of fluid when you have major burns like that. So all of those are underneath hypovolemic shock. Okay, so number 2 was cardiogenic shock, and that's a pump issue, right? So something's wrong with the pump itself. It's not moving blood through the body because it's not able to pump correctly. So what are some things that could cause a pump problem? Heart failure. What else? Cardiac tamponade. Okay. That would be more like an obstructive shock, actually, because the heart is still able to beat, but it's just being obstructed in a way, right? Yeah, so a mechanical problem like a ventricle rupture or a valve issue, myocardial infarctions, which is what? A heart attack. Good. Okay, so that was category number 2, cardiogenic shock. Okay, what's category number 3? Okay, obstructive. And what does that mean? A blockage of some sort. Yeah, the blood flow is obstructed by something in the system. So that could be what? What are some different things that could obstruct that? Okay. Tension pneumothorax, cardiac tamponade, pulmonary embolism. Perfect. And then what's our last category? Distributive. And what kind of problem is that? Like we have the pump problem, we have the fluid problem. Distributive shock is what kind of problem? It's like a pipe problem, right? Because the pipes are having a difficult time distributing the fluid throughout the system, right? So what are some things that could lead towards distributive shock? Okay. Okay, yep. Neurogenic, good. Okay, yeah. So why does anaphylaxis why can it cause distributive shock? Okay. Okay. Yeah, so anaphylaxis causes that vasodilation, and it also causes increased vascular permeability. Do we remember about that? Yeah, okay, good. So neurogenic shock, that's, injury to the brain or spinal cord. There's also a major vasodilation with brain and spinal cord injuries. And then septic shock. So septic shock could fall under a few different categories. I think it talks about that in your book a little bit. But septic shock is basically like a systemic infection that's causing an inflammatory response. So that inflammatory response causes blood vessel dilation, which would be that distributive shock, right? And it also increases capillary permeability. So it allows more fluid to shift out of the pipes, right? So that would be a volume problem. What was the volume problem called? Hypovolemic shock, right? And then sometimes it can affect the pumping ability of the heart. So what kind of shock would that be? Cardiogenic. Good. Okay. Okay. So the body's response to shock, any type of shock under those 4 categories, the body's going to have a response to that. So typically we start with that fight or flight response, which is stimulated by the sympathetic nervous system, right? So baroreceptors are located in your aorta and your carotid sinus. What do baroreceptors sense? Do we know? Pressure. So they read the pressure that's in those big major arteries. And so when there's a drop in that pressure, it signals that baroreceptor picks that up, and it signals the body to release epinephrine and norepinephrine. So that's released into the bloodstream. What are epi and norepinephrine referred to as? Do we know? Huh? Adrenaline. Okay. How about sympathomimetics, right? Because they are they mimic that sympathetic nervous system, right? So epi and norepi, they cause blood vessel constriction in the skin, kidneys, and GI tract first. When this is triggered, that's where it kind of pinpoints to. So when it hits the skin, it's shunting blood away from the skin. Okay, sorry, let me back up. When we have the epi and norepi in our system, blood is shunted away from the skin, kidneys, and GI to more important organs like our brain and heart, right? Because hypoperfusion, shock, our most important organs need that blood first, right? So it's shunted from our periphery to the core. Does that make sense to everybody so far? Okay. So when vessel constriction occurs in the skin, what are some things we might see? Pale. Good. Sweaty. Yeah. So when someone's in shock, they're going to appear pale, cool, and diaphoretic. What does diaphoretic mean? Sweaty. Good. Okay. So when that blood is shunted away from the kidneys, that's going to cause the kidneys to produce less urine to prevent fluid loss, right? Because we were already losing fluid. We don't have enough circulating, so we want to retain as much as we can. And then GI vasoconstriction causes the stomach to try and empty its contents, leading to nausea and vomiting. Okay. So compensation. Tell me what compensation means in the body in reference to shock. The body's trying to fix itself and maintain that homeostasis, maintain your perfusion, right? Yeah, so that's the body's attempt to compensate for the decrease in perfusion and pressure. So we talked about the baroreceptors a little bit. They're also called stretch receptors because they pick up that pressure in the aorta, the carotid sinus. Yes. And then we also have chemoreceptors that sense changes in the chemicals. So chemical, they look at the oxygen, CO2, and the body's pH. So when those things decrease, so a decrease in pressure delivers less chemicals to those chemoreceptors, and that triggers vasoconstriction because we're trying to get more fluid going through quicker. Okay, so compensation is also known as compensated shock. Get where I'm going here. Okay, so in compensated shock, we might see decreased urine output. Why? Correct. Yeah, we want to keep as much fluid as we can. We might see cool, pale, diaphoretic skin due to that shunting. We're shunting all of our blood towards the core, right? We will probably see an increased heart rate and respiration rate. So why would we see an increased heart rate? Right, yeah. So the body released that epi and norepinephrine that increases our heart rate to try and compensate for that low pressure that's in our veins. And then we might see normal or decreasing mental status in compensated shock. That increased heart rate and respiration rate, we might be able to compensate and perfuse our brain well enough to maintain that mental status, but we'll talk about in decompensated shock, the mental status is going to decrease significantly. Okay, so why do we think the body would move from compensated shock into decompensated shock? Because it can't keep up anymore, right? Yeah. So during compensation or compensated shock, all the muscles in the body are working hard to keep up. Smooth muscle in the blood vessels are constricting. The heart muscle is straining to pump harder and faster. And your chest wall muscles are working a lot to increase the respiration rate. So like we just said, eventually the muscles grow tired, and that leads to decompensated shock. Okay, yeah.
What would be an example of vasoconstriction not being possible in distributed shock?
Say that again, sorry.
It says vasoconstriction not possible sometimes in distributed shock. What would be an example? Like when your veins aren't able to vasoconstrict?
So like if a patient has distributive shock, that would be like, what did we say? Yeah, so, right. Then that sucks. They're going to decompensate a lot faster, right?
What would be like an example of that?
I mean, that anaphylaxis would be one thing, right? Like they have the vasodilation. Sepsis might be another one. You know, neurogenic shock where their brain's spinal cord is injured. Yeah, pretty much, yeah. Yep. Okay. Let's see. Okay. So this compensated shock state started because our body had a lack of perfusion. So the compensatory mechanisms that our body is producing here, they also require oxygen to work, right? When our heart pumps faster, it requires more oxygen. When we breathe faster, our body's using more oxygen, right? So that's going to lead us to decompensated shock quicker, because the quicker our body uses that oxygen, the quicker we're going to decompensate, right? Okay. So if we don't fix the underlying issue that's causing the shock, then we will continue to decompensate, and the muscles will run out of fuel. So then we go to decompensation, which is also known as decompensated shock. So this is like what we just said. When compensation eventually fails, compensated shock becomes decompensated shock. So yeah, there's a drop in blood pressure because that heart's not able to pump as hard and as fast anymore, right? A worsening mental status because our fluids aren't, our blood is not perfusing through the body to the brain, so our mental status is going to decrease. Bradycardia, that heart just gives out, right? It's been pumping so hard and so fast that it can't keep up anymore. And then a slowing respiration rate or apnea can occur. And then if we don't fix the problem there, it'll go even further to irreversible shock or death. So prolonged hypoperfusion leads to permanent organ damage. So our brain, our heart, you know, if those things aren't getting oxygen, there's permanent damage that can occur there. So uncorrected shock can lead to cardiac arrest, permanent organ damage, or death. Okay. So during our assessment of a patient that we believe might be in shock, we need to identify the underlying problem that's causing it, right? So we can sometimes get clues from our scene, like, you know, are they around bees? Are they allergic to bees? Like, do we see a sting on them? You know, are they in anaphylactic shock? You know, have they been sick for months and months on end, which could lead to septic shock, you know, things like that. So we just need to figure out the cause that's causing them not to perfuse. So the airway is not usually a cause of shock, but we want to correct any issues there, of course. Breathing, so a low pulse ox and signs of hypoxia should be treated aggressively with oxygen. We can consider attention pneumothorax and assess breath sounds. And then circulation, so we want to look at their skin color, feel for pulses. Is it strong and bounding, or is it weak and thready? We can look at their cap refill time. How quick should our cap refill be? Less than 2 seconds, right? So if they're not perfusing well, or if they're shunting that blood to the core, their cap refill is going to take longer. Of course, we want to control any bleeding that we see, and then we want to watch our blood pressure readings and trend that. So if it's getting lower and lower, we know we're kind of decompensating there throughout the call. So treatment, again, it depends on the underlying cause of the shock. If it's anaphylactic, we need to treat their anaphylaxis. If it's a bleeding problem, we need to stop the bleeding, right? So we want to initiate transport, prevent hypoxia, prevent heat loss, consider shock positioning. Why do we think that we should lay a shock patient flat? Yeah, it's easier to like get the blood flowing to all the areas if you're laying flat, right? Doesn't have to work up against gravity to the head, to the brain. And then we want to consider ALS. So, sorry, let me get back to where I'm at here. Okay. So next is about bleeding. So external bleeding. Hemorrhage is the major cause of shock and trauma. That can be external or internal. External bleeding, though, what does an arterial bleed look like? How does that present? Bright red, spurting blood, right? What about venous bleeding? Dark red, yeah. And then, yeah, what about capillary bleeding? Oozing. It'll maybe sometimes stop on its own. Good. So determining the type of bleed is unimportant when you're on a call. It doesn't really matter what kind of bleed, like, you know, it doesn't matter if your patient has arterial bleeding or venous bleeding. Like if they're bleeding enough they're going to lose too much fluid, and we need to stop it regardless of what type it is, right? And then bleeding can be accelerated by underlying conditions, like if a patient's on blood thinners, hypothermic, if they're hypothermic, that can cause them to bleed out faster. So there's kind of a picture of your different types of bleeds. Arteries are that spurting, pulsating with the heartbeat. Veins, steady, with a dark red color. And capillaries are just a little bleed. Okay, so how do we treat a bleed? What's step? Direct pressure. What if that doesn't work? Tourniquet. Good. Okay. Yeah, so an additional step they added in here is wound packing or hemostatic agents. What is a hemostatic agent? Good. Yeah. Okay. So yeah, tourniquets are only used on extremity injuries, right? We want to place a tourniquet high and tight. Some people say place it 2 inches above the injury, but it's just easier. Just pull it all the way up and tighten it high and tight, right? And then we don't want to place those over a joint. Other methods of bleeding control, we can elevate the extremity if it's an extremity. If it's like a fracture of some sort that's causing it to bleed, we can splint it in a place where that kind of helps control the bleeding. And then sometimes cold application can help too. So the wound packing and tourniquet stuff, have we practiced that at all in the class? No? Okay, we'll get some things out after this PowerPoint and kind of talk about wound packing and tourniquets. Okay, internal bleeding. What can we do for internal bleeding in the field? Drive fast, right? Yeah, there's not a lot we can do for internal bleeding, but we can try to identify it, right? It's harder to identify because we can't necessarily gauge how much blood the patient's lost. We don't have x-rays or scans or anything to see if that's actually happening, but we could see battle signs or distension of the abdomen in abdominal bleeds. That's a good indicator of a bleed. Blunt trauma is the leading cause of internal bleeding. So then treatment, basically what we just said, right? I mean, we want to control the ABCs. If there's any external bleeding, we want to get control of that. And then shock treatment. So is that the sheet you guys have? Yeah, bleeding control and shock management. Yeah, we'll go over that in a little bit too, but we want to keep the patient warm. We want to lay them down. We want to give them oxygen, treat for shock, and then rapidly transport them. So this is a pretty blurry picture, but these are some different signs that you might see when there's internal bleeding going on. So this is Cullen's sign. It's usually right around that umbilicus area. And then the other one is called Gray-Turner's sign. So that's like bilateral flank bruising. So this one could occur with, seat belts. That could be your seatbelt sign. They might also have that across their chest, but if you see things like this, like that's pretty indicative of some sort of a bleed going on. Okay, yeah, this is your sheet. We'll talk about that in a little while. Okay, bleeding, other. Okay, so head injuries. Bleeding or loss of cerebrospinal fluid from the ears and nose is caused by increased ICP. Do we know what ICP is? Intracranial pressure, right? So if we see blood coming from the nose or the ears after a head injury, we don't want to try to stop that bleeding, because if we pack the ear or we pack the nose, that can increase ICP further. And then nosebleeds. So do we lean forward or backwards for a nosebleed? Forward. Okay, good. Yeah, so sit down, lean forward, pinch the outside of the nose for 5 minutes without checking to see if the bleeding stopped. Why don't we want to check for 5 minutes? Because you could, disrupt that clotting process. Okay, any questions on shock, bleeding, any of that? No? All good. Okay, cool. So let's take 5 minutes. We're going to get the wound packing tourniquet stuff in here, and then we'll do that for a little bit, okay?
It was so mellow tone. The air is very, very.
Did you guys have any questions online, or you good over there?
I win.
This is on. I'm gonna.
Cool. What is it?
If you can do it accurately.
On what?
The pounds of pressure that you apply after wound packing.
Oh. All right. So, got some that's freaking open. Oh, you got some galls over there? Oh, okay. Cool.
All right. So we're gonna go over wound packing. Not everyone's in here. We'll go over it a few times. So the trick to wound packing is you're trying to find the source of the wound. So this one's legs or functional or whatever. You actually put the ear in and try and bleed it with your fingers. And then you'll take your gauze. And you want to kind of wrap it around your finger like this. So as you're packing, you're trying to put pressure where it's bleeding, and then you're stuffing it in. And as you stuff it in, you pack it out. Obviously, that bleeding is coming from more than one place. So try and locate it if you can. Sometimes you can feel where that wound actually goes outside the artery. So you're wanting to put a lot of pressure on it. So as you're packing, you're doing like this scissoring packing technique. And you're holding pressure. Does that make sense? So as you're holding pressure, you get all the packing done. Once your packing is all done, you want to apply pressure. So there's a certain amount of pounds that you're going to apply whenever you pack. It's like 15 to 30, I can't remember. I'll look it up. So after you're done packing, you're going to put whatever you have left or like another pad like this over the area, and you're going to hold pressure. And then you're going to hold it for 3 minutes. Till the bleeding stops.
I just until the bleeding stops.
Yeah, till the bleeding stops. If you're in a situation like this, you're just gonna try and control that bleeding. Because this is like what I would impact a paper cut on my finger. If someone shot like in the junctional area, this is where this comes in. Because if you can't get a tourniquet up higher, or if you put a tourniquet on, you just can't get it to stop bleeding. It's best done with like a hemostatic gauze if you have it. Why? Yeah. All right, trick question. If somebody has a bleeding disorder like hemophilia or von Willebrand's disease, will hemostatic gauze work? The clotting factor will not work, but the gauze itself will still be gauze, but the clotting factor is not going to work. We can tourniquet.
Tourniquet. All right. So the cat tourniquets are the most common tourniquets you'll find on ambulances. There's a couple of different models of tourniquets. They have the ones that have the little windlass on them that you turn, right? They've got some. I think there's one in there that's like it's got some weird little ratchet strap thing to it. I know Billy's got one that's like a piece of paracord wrapped around like a piece of metal, and it works. It would work probably for enough time to get you like a good solid commercial tourniquet. So there's a couple of different ways, right? You can take like if you're out in the middle of the woods, you can rip a shirt up, tie it around a stick, tie it real tight, stuff like that, right? These right here will absolutely kill a patient if they are not put on appropriately. What is the purpose of these tourniquets? To stop blood flow. Okay. What type of blood flows close to the skin or the surface of your extremities? Is it Venous or arterial? Venous, right? So I can take this tourniquet and I can stick it on your arm and cut off the venous supply of blood. Where does your venous blood flow go? Up to your heart, right? So I can cut off the supply of blood that's going back to your heart, but not do this good enough to cut off the arterial supply going to that extremity. And I've seen it done. I've seen somebody put one of these on, it cut off the venous supply, did not cut off the arterial supply. And where does the blood go? Out of the path of least resistance, which was the cuts in which this man had on his legs. And it actually made the bleeding worse because all the blood was going down. And when it come back up, it just went out of the cuts that they were trying to tourniquet off, right? Please make sure you apply these appropriately. It's going to suck. It's going to hurt. Sorry. I hate it for you. So whenever you apply these tourniquets, how do you want to apply them? High and tight. That's kind of the general rule of thumb, right?
The reason we teach that is because if you're coming on pain and you're seeing an extremity in my pants and that pants is full of blood, if you don't have time to cut it off and you know that there's 2 minutes out of pain, you go high and tight and then shot somewhere down here. I don't have to try and find a wound and be like, okay, 2 inches above and then put it there. It's just a lot faster to go high and tight. So you can go high and tight, and then once you get a second to assess, you can reassess. If you need a second tourniquet, you can put a second tourniquet on it. But high and tight is your best option.
And you can stack 2 tourniquets. I think now the protocols for these tourniquets are they can stay on for what, up to 24 hours.
Oh yeah, they've done studies where they don't lose neurological function for like 7 years.
So don't be afraid to use one. Oh,
I think one thing I forgot to mention too is once you put on a tourniquet, you don't take it off, right? Like
Correct.
you leave it on.
yeah. So whenever you put these things on, high and tight. So this initial pull of this thing should be tight, right? That should go on there pretty tight. I mean, even initially, like this thing's on here tight,
You shouldn't be able to put a finger up under this.
right? So when I go to turn this, I shouldn't have to turn this thing more than about a rotation and a half to 2 rotations. If you're sitting there freaking spinning this thing around like it owes you money, and then you don't have it tight, right? So if you look, that's a half a turn.
That's good for me.
That's 1 turn, right? Yeah.
At least.
That's 1 more half turn, right? Let me take this thing right here. I'm going to shove it down in here. And then what do? Put the time on it, right? And so whenever you do these, you can come down to the end of her arm. Your poor arm.
This is poor cap refill.
So it's like I've done this once or twice.
Mm-hmm.
I actually have a certificate for putting the most tourniquets on in the city of Atlanta 1 year. So, yeah. So check pulses, right? Make sure you've lost pulses in this extremity. It's not going to be comfy. I know she's not comfy. It's not going to be comfy, but you have to put these on appropriately. If you do not put these on appropriately, you can make your patient worse. We're going to go over this on Saturday. We're going to have tourniquet races. You're not going to put them on me. You're going to put them on each other because it freaking sucks and it hurts. I don't want to do it.
And if you have one for like your personal use, I'm just gonna pass these around so y'all can look at it. If you have one for your personal use, the manufacturer's recommendations of these, they come like, what's that called? Yeah, like prepackaged. They have like this plastic seal on them. Per the manufacturer's recommendations, you should not carry them with the plastic seal on them. You should take it off and carry them like this. Have you ever seen one of these before? I think that's all of them. Just pass them around once you've looked at it. Yeah.
So, fun fact, just because I told Becca that I would show y'all. Who has a half-empty water bottle? Let me borrow that water bottle, son.
No water.
So you can make junctional tourniquets out of these things.
What's a junctional tourniquet?
So if I have somebody shot right here, will this tourniquet work on them? No, right? So you can go out and spend like $2,000 on these things called junctional tourniquets, which are really fancy. Or you can take a water bottle and a couple of cat tourniquets and do the same thing. Yeah. So what you do is you take 2 cat tourniquets,
Oh, you're gonna have to grab one more.
and this isn't going to be on any of your tests, so don't expect it to be. But this is a fun fact, because if you ever run into this issue, you'll know how to do it, right? So you take 2 of these junctional tourniquets, you pull them apart, or 2 of these regular tourniquets, you pull them apart. Here, patient, will you hold that? And that.
Mhm.
You can use half water bottles. You can use the saline that we have in the back of the ambulance. Whatever you need to do to make it work. So I can take 2 of these tourniquets right here and I can wrap them around her waist, right? So if old Beckadoo is shot up here, I could take 4x4s, stick them in this wound, take that bottle right there, half empty, stick it in that wound, and then I can ratchet this tourniquet in there to make a junctional tourniquet. If you do this, somebody's going to look at you funny, but I promise you it works. I've done it. I picked up a guy at an Exxon gas station in the middle of Atlanta and did this same exact thing, and it works. So that's a good, easy way to make a junctional tourniquet. You can do the same thing with somebody's arm. If you take 4x4s and shove it up in their arm, shove this water bottle up in there, put this arm beside them, and wrap this tourniquet around them, you can do the same thing, because all it does is hold that pressure in there. No. You can use that hydro flask if you really wanted to, but it just
The more full, the better. Like the harder material, those will still work. But
the reason why I like using the half full water bottles is because they have a little bit of give in them. So as you tighten that tourniquet down around this thing, it kind of compresses this and makes this flat, so it sits like this, and so it kind of flattens down onto that. I mean, you can. I actually, somebody that I knew from Atlanta used to carry tennis balls around. The guy that showed me how to do that used to carry tennis balls around for that exact reason. Yeah, use big rocks.
grab a rock.
But the guy that taught me how to do that used tennis balls to do it. So anything round, kind of hard, it'll work. But that's just a informational tidbit, because there is a time, like you're working at the mine, something slips and freaking nicks an artery, and they can get real ugly real fast. So, yep. Mm-hmm.
Yeah.
Yep. Pelvic splints work the same.
Pelvic splints, they actually look exactly the same, except for they just got the extra little pump things, which where you would use the water bottle, they have little pump up things that go in the same spot, but they look the same.
The
The
Sam,
junctional,
the junctional tourniquets,
They're
I think they're like
expensive.
$1,500.
Yeah, they're spendy.
Yeah. Well, I need to know where you get your pocket change at. Yeah. Yeah, have the mine put in for them, because they ain't putting in for them around here.
Sam pelvic splint, and then stick pressure bags,
Oh yeah.
and then you can actually inflate them with an
Yep.
oxygen bottle and cross clamp that aorta and kill all blood flow down, but reroute it up to the lungs and the heart.
So there's a couple of different ways. I am king of MacGyvering. I like to MacGyver things. So that's just a fun little MacGyver tip that you can use. I don't think that they have enough like circumference. Like you can't wrap the vacuum splints, and they're so big because the vacuum splints are only for like extremities or full body. So like the small one's still like this big. So I mean, you could, but it'd be like you'd look really goofy. It'd look even more goofy than just using a tennis ball, huh? I mean, the one that we took in, the
I
doctor was
wanna hook
like,
this thing up
"The
on
freak is this?" And I was like, "He ain't bleeding," and he was like, "You're right." And I was like, "All right."
So once you put the tourniquet on, don't take it off. There's few exceptions to that, and that's none of them. All of that is like wilderness medicine, like whenever your day's out, like there's exceptions, but per this class, you never remove a tourniquet. So
Yeah, don't take them off.
yeah.
Hmm?
Oh yeah. Yeah, so Hannah did mention not to put them over joints. Why can't we put it over a joint? Yeah, and then if they move their arm, they're going to loosen it up or slide it around. So away from the joints, go above the joint. All right. Any questions on tourniquets?
And where do we pack wounds? Where by your textbook are you not supposed to pack wounds?
Yeah.
Well, it's essentially a open cavity, right? And so if you go down the rabbit hole of trying to like pack a chest wound, there's so much empty space in here that you can fill up their entire chest cavity with 4x4s, right? So, if you go in, if you've got like a wound, they say from nipple to navel or neck to navel, if you've got a wound in that area, you don't want to sit there for freaking go through 4 rolls of gauze trying to pack this thing. You're just not going to be able to. If you take a handful of gauze and like shove it, just kind of right there at the surface area and put pressure on it, that's one thing. But don't spend freaking 30 minutes trying to shove 4 rolls of gauze into there because you're just going to run out of gauze eventually.
Mm-hmm. Just above it, yeah. Yeah, usually above it. If you can't go up any higher, you can go below, but they recommend just putting one right above it. And most of the time, whenever you're dealing with like leg wounds, there's so much adipose, like extra tissue in the legs, that you're gonna need 2 tourniquets anyways. Not mine because I got chicken legs, but most people. So.
And whenever you do that, don't leave a big gap between the 2 of them. You can cause like compartment syndrome and stuff like that in patients. So be careful whenever you are applying multiple tourniquets. Put them close together, right? So you don't want to put one like up here and then one way down here. If you're putting one up here, then put one, just above it or below it, wherever you can fit it. But put them close together.
You got a bleed in the tip area, you just still put it up.
Listen, man, I'm an advocate of tourniquets. You can ask her. Me and her had this discussion one day because we had a guy that was shot like 14 times in his leg. He wasn't really bleeding that bad in any of his wounds, but to control all of them without sitting there trying to like bandage up everything, I just put a tourniquet on his leg. She said that she wouldn't have done that she would have gone the other way, right? So there's differences in medicine. People have difference of opinions. To me, it was just easier. I just put a tourniquet on him. He could sit there for like 72 hours. We got a 25-minute ride to the hospital. Like, he's not going to die. He's going to be a little uncomfy, but he'll be all right. Again, I'm an advocate for them, especially if you know that the patient is going to be in the hospital within a couple of hours. If that's like, obviously, like Becca said, if they got a paper cutter on their finger, don't put a freaking tourniquet on them because then you're going to look kind of goofy. But if there's any significant bleed, I've had open tib fib wounds that I wasn't able to get a good enough amount of pressure around the wound because their bones were so broken up in that area that I couldn't take any like 4x4s and kind of get that like pressure built up right there. Tourniquet and be done. Move on. And it's easy for me to say that. Whenever you're presented with a situation the first time where you're like, should I do it? Should I not? If you're contemplating like whether you should or shouldn't, just put it on there and let the hospital deal with it because Worst case, they're a little uncomfortable for a couple hours.
Iron sight for that area or even down here, your forearm, iron sight would be up to the joint, right? Not all
So
the way
the
here, all the way to the top.
Yeah. So
You
the
can, like, if their whole arm's exposed and you see the cut right here and you go here, nobody's gonna say anything.
it's fine,
But like, say his, shirt was down, he got flown out of his vehicle,
and I'm just pouring
and he's
blood.
pouring blood. I'm gonna come up here because I don't know where all he's cut, and I'm not gonna sit here and go, okay, there. I'm just gonna put on a tourniquet. Yeah.
And if you have to put on multiple tourniquets on multiple extremities, that's fine too. I've put up to 3 tourniquets on one patient before. Bilateral arms and a leg.
And keep in mind too, like whenever we have bone breaks, like a femur break, even if it is closed and they're not externally bleeding, and you look at this patient's leg and this leg's this big and this leg's this big, you might have to put a tourniquet on even though there's no external bleeding, because they're still bleeding into their leg, because what runs right next to our femur? There's an artery that runs right here,
The
a
femoral
big
artery.
artery. So you think about time it takes to bleed out with severed arteries, it's within minutes. So it takes like within 2 minutes that they're dead, like they've lost their blood volume. So if you're seeing something like that and it's progressed, throw a tourniquet on them.
And she says that because we've had to do that before.
Yeah, we got yelled at by the doctor because they're like, "Oh, they're
Why
not
the frick is
bleeding."
there a tourniquet on
And
her
then they
sweater?
popped the tourniquet off, and
And our blood pressure went.
Yeah. So,
I was
but
like,
it's
that's why I'm stupid.
Yeah. Yeah, that was it.
Freaking.
Yeah, the traction. I lost the fuzzy.
Yeah. So you can strap the traction splints on there kind of tight, but the problem with the traction splints is they have a lot of elasticity in those straps that go like kind of. So you've got the big one that goes up here that kind of buckles in. You kind of strap down, but everything below that is kind of elastic, and so you're not going to get a lot of like tourniquet application out of them. So if you do plan on tractioning somebody, as well as putting the tourniquet on them, put the tourniquet on them first and then traction them if you need to. Honestly, the traction splint is going to be at that point more of a pain reduction thing, because the whole point of like the tractions, well, one of the big points of a traction splint is you don't want those bones in there flopping around and potentially nicking that femoral artery. And so if it's already like cut open, at that point, the traction splint's more of like the pain control aspect, which the first time you ever use one, you'll know what I'm talking about. You'll have patients that are like screaming bloody murder. And then the second that femur gets back in place, they're just like, oh. So it does work. If you need pain control with a broken femur, traction it works out fantastic.
Anybody need bathroom or anything, or is everybody good? Good. Okay, cool. All right. So chapter 30 is on soft tissue trauma. What is included in the term soft tissue? Yeah, anything but the bones, pretty much, right? And cartilage. We don't include cartilage in soft tissue either. So soft tissues include skin, fatty tissues, muscles, blood vessels, connective tissues, membranes, glands, and nerves. And like we just said, they don't include teeth, bones, or cartilage. So pretty much everything except your bones. So the most obvious soft tissue injuries are going to include the skin, because that's what we can see on the patient, right? So the skin is a body organ, right? A lot of people forget that the skin is an organ, but it is. It's the largest in the human body. So what are some of the functions of our skin? Protection, temperature, what else? Yeah, okay. Yeah, protection, water balance, temperature regulation, that's one. Excretion, so we sweat, we have sweat glands, sebaceous glands. It impact absorption, so if we get hit, it kind of helps absorb that impact, right? And then the skin nerve endings provide sensory input as well. So 3 layers. What are the 3 layers of our skin? Yeah, epidermis, dermis, and the subcutaneous layer. So the epidermis is the outermost layer, epi above, it's on the outermost layer. It's comprised mostly of dead skin cells, and it contains no blood vessels or nerves. The dermis is the second layer right underneath the epidermis. It's rich with blood vessels, nerves, sweat glands, sebaceous glands, and hair follicles. Oh, and then the subcutaneous layer is that like fatty layer. That's the deepest layer of our skin. It's comprised of fat and soft tissue, and that helps with that shock absorption and insulation. That fatty layer helps with temperature control. So closed wounds. What's a closed wound? Huh? One that's not exposed to the outside, right? Yeah. So it's closed. It's an internal injury. There's no open pathway from the outside of the body to the injured site. The skin remains intact. So there's a couple different kinds of closed wounds. A contusion. What's a contusion? A bruise. Okay. Yeah, the skin remains intact, but the cells and blood vessels in the dermis are damaged. And then there's a hematoma. What's the difference between a contusion and a hematoma? Amount of blood, yeah. So a hematoma occurs when blood collects at the site of an injury. So bruises are typically like flat. You know, we've all had a bruise before. We know what they look like, right? But a hematoma is a little different because there can be more swelling. That blood can pool underneath the skin. It could become raised. It's usually a larger amount of tissue damage there. We could have closed crush injuries. So blunt force can cause internal organs to be crushed or ruptured, causing internal bleeding. So we already kind of talked about that there. So for a closed wound, how are we going to treat them? Huh? Calming words. I like that. Yeah. We're going to manage their ABCs, provide care for shock if you suspect that there's major internal injuries. Like we talked about previously, like we can't do much for an internal bleed, but we can, manage, treat for shock, right? Keep them warm, lay them down. We can splint extremities that are painful, swollen, or deformed. And then we can also sometimes use cold packs to isolate I think that's supposed to say cold packs on isolated injuries to manage pain and swelling. Open wounds. Okay. So what's an open wound? Where the skin is broken, right? Yeah. An injury in which the skin is interrupted, broken, exposing the tissues underneath. So there's a few different types of open wounds. So there's an abrasion. What's an abrasion? Just like a scratch, right? Yeah. And then what's a laceration? A deeper cut, right? Yeah. And then we can have penetrating trauma and punctures. So that's when an object passes through the skin or other tissue. Puncture wounds are considered more serious injuries. We can have avulsions. What's an avulsion? A flap of skin, right? Sometimes they're called deglovings if it involves the hand. I'm going to have a picture of one in a minute. We can have an amputation, which means what? Fully cut off, right? Yeah. So we had closed crush injuries, but we can also have open crush injuries. So that can result when an extremity is caught between heavy items, such as pieces of machinery. And then bite wounds. So bite from an animal, from a dog, from a human, maybe. Infection rates tend to be higher in these type. I mean, it happens. You never know. So, okay. We can also have blast injuries. That's when a patient's injured from a blast and they can sustain a combination of all of the types of injuries. So they could have penetrating wounds, they could have blunt trauma, they could have closed or open wounds, just depending on, how big the blast was, what happened, how close they were. And then there's those high pressure injection injuries, which are, I would say, less common. I've never seen one. So they're sustained when a patient's working with a machine that injects grease, paint, air, or some other substance under high pressure.
So these high pressure injuries can also include stuff like pressure washers, stuff like that. which a big issue with those is like air getting into the blood and causing like emboli, pulmonary embolisms, stuff like that. So that's partially what that's referring to too. If you've ever been working on a pressure washer and kind of nicked the bottom of your foot or something like, we had a guy over here a handful of months ago that took out a chunk of his hand with a pressure washer. So that's included in that too. Just be aware. And be aware that pulmonary embolism is a big concerning factor when it comes to those.
Cool. So here's some pictures. Kind of know what those look like. Amputation, avulsion, crush injury, can be open or closed, puncture wound, abrasions, lacerations. And then this would be like a laceration to the head there. And then this is our degloving injury on that side. That looks great, doesn't it? Yeah. Yeah. This is just what I could find on Google. So, and then this was reported to be a crush injury. Would this be an open or closed crush injury? Open. Good. And then the one over there on the bottom right that was reported to be a high pressure, what was it called? The high pressure injection. No, he's got all his toes. Yeah. I guess that could be like an avulsion from the bone, maybe.
Yeah, they're just a little displaced.
Yeah.
So this one with the hand is like a lot of time, you have different size pressure washer heads, that stream out different ones. And that's probably what that's from, is from like a pressure washer. Somebody's in there and accidentally pops their hand. You could shoot water up under your skin. You can shoot air up under there. It can cause a lot of really major issues. So if y'all ever go on one of these, just be on high alert for a lot of changing in conditions with these patients. No, electrical injury goes under its own little category, just like electrical injuries aren't just isolated to one place most of the time. If you go in and like pop yourself with the socket in your house, you just kind of get the nice little shock. That's one thing. But like if you go in there and if you're working on like electronics at your house or electrical systems in your house, that electricity will travel through your body. And so it'll go from point of contact to like a grounded area of some sort. And so you'll see like blast out injuries from, like it'll go out of their hand and blast out, their fingers. It'll cause dysrhythmias in the heart. But electrical injuries are in their own little category of injuries. Do we go over that next week?
It's at the end of this. Yeah.
So yeah, it's in its own little category of injuries.
Okay, cool. So open wound treatment. So we want to expose the wound. If we just see bleeding, like we talked about earlier, like we want to try to cut the clothes off, expose that wound. We want to roughly, not roughly as in like rough, but kind of clean the wound, right? Like we're not going to get all up in the wound and like try to get every little piece of everything out, right? But as best we can, we want to try to get it as clean as possible. Obviously, we want to control the bleeding and then provide care for shock. Anytime there's like major bleeding, we want to throw that shock treatment, shock care in there with it. We want to prevent further contamination by dressing and bandaging the wound. We want to try to keep the patient as still as we can to prevent further injury. And then we want to provide calming words, reassure them, right? So what's a dressing? Okay. So a dressing is the material that's applied to a wound in an effort to control the bleeding and prevent further contamination. So that's like what goes directly on the wound. Those, we try to make those sterile, but sometimes they're not. And then what's a bandage? The wrap or whatever holds that dressing in place, right? So then We can have pressure dressings, which control bleeding, and then occlusive dressings. Occlusive dressings are used to form an airtight seal when caring for open wounds to the abdomen, chest, or neck. Okay. So it goes into some specifics, but I think they're pretty self-explanatory. Like abrasions and lacerations, we want to try to get it as clean as we can, dress it, bandage it, control the bleeding. Penetrating trauma, we want to reassure the patient, try to keep them as calm as we can. Search for an entrance and possible exit wounds, and then control bleeding and treat for shock. Impaled objects in general, we don't want to remove impaled objects. We want to try to stabilize them in place, but why do we not want to remove an impaled object? Cause more damage on the way out, cause more bleeding. Yeah. Okay. Yeah. So what about if it's an impaled object in the cheek? Should we leave it or remove it? If Mhm. So I've always been taught if it's causing an airway problem, remove it, right? Because if they're going to die because their airway's blocked, then that's probably more important than, stabilizing the cheek penetration wound or whatever. Okay. I think it said in the book, if it's perforated through the cheek and you can see both sides, then you can try to remove it. I'm pretty sure is what it said, unless I read that wrong. Yeah. Right. Okay. So
Listen, don't take it out. Leave it there. If it ain't messing with nothing, freaking don't mess with it.
Right.
Because it can cause just as many injuries coming out as it can going in. So I don't care how many ends of that bastard you can see. If it ain't affecting their airway, leave it there.
Yeah. Yep. So then impaled objects in the eye, we want to take it out or leave it in? Leave it in. Right. So why are we going to cover their other eye that's not affected? Because your eyes move at the same time, right? And if the unaffected eye is moving, the injured eye is going to be moving too, and that's going to cause more problems. Okay, so treatment for avulsions. So we want to try to kind of clean the wound if we can. It says to fold the skin back to a normal position if that's possible. We can apply bulky pressure dressings, and then we want to try to preserve the avulsed parts for possible skin grafts at the hospital. There's your cheek penetration wound. Yeah, that's a fake. That's fake. That's makeup. But yeah. Yeah.
That's a crazy ass girlfriend.
Yeah. Okay, and then treatment for amputations. What are we going to do with the amputated part? Bring it with, right? How are we going to package it? Bag it up, put it on ice. What? Right. Yeah, so we want to wrap the amputated part in sterile dressings, bag the amputated part and keep it cool with cold packs. But yeah, we don't want it directly on ice or on that cold because it could freeze. We don't want to directly submerge it in water or saline either. Like, we just want to put it in a bag, keep it cool. And then we have our genital injuries. So we want to try to control bleeding, treat for shock, preserve any avulsed or amputated parts. And then, yeah. And then we want to also inquire about possible sexual abuse. Like, these are pretty uncommon injuries, like to have something amputated or avulsed, but yeah.
I've seen people stabbed in their nose.
Yeah. So yeah. There's that.
Yeah, it wasn't great. Anything. Crackhead got shanked in the vagina.
Okay, go ahead. Okay, so an occlusive dressing taped on 3 sides would be for like a chest injury, right? Because if we tape it on all 4 sides, pressure is going to build up in the chest while the patient's breathing, right? So we want to have that open corner so that the pressure can release from that chest cavity. Does that make sense? Okay. Any other questions on any of this so far? No? Cool. Okay, burns. Burns can affect more than just the skin. They can also involve muscles, bones, nerves, and blood vessels. So when we're trying to classify burns, we want to classify them by the agent and the source, by the depth, and by the severity of the burn. So classifying the agent by the source, or classifying by agent and source. So we can have thermal burns, chemical burns, electrical burns, light burns, and radiological burns. And so for thermal burns, that would be like heat, right? So that can come from several different sources. That could be fire, a hot stove, wherever the source of that thermal energy is coming from, that would be your source. And then so on and so forth. Chemical, we could have acids, bases, or caustics. Electricity, alternating current, direct current, lightning. Light, there could be intense light sources that can damage the eyes. And then radiologic, usually from nuclear sources. We don't typically see a whole bunch of that, but it's possible. So then classifying the burn by depth. So what is a first degree burn? Sorry, I'll go back to that. Yeah, superficial, like just that first layer, the epidermis, right? Sometimes, or it's usually looks like a sunburn. Just that red, not a whole bunch of swelling, might be a little bit, but nothing crazy. Reddening of the skin. Yeah. So second degree burn, what is that? Partial, and it goes down to what layer? The dermis. Okay, good. Yeah, so it's patients will typically have a deep and intense pain. There's reddening, blisters, and sometimes mottling of the skin. And then a full thickness or third degree burn, that's all the layers of the skin are burned. Some areas might be charred, black or brown, and then others might be dry and white. They might have severe pain or no pain at all. Why would they have no pain? Because it burns the nerves, right? Yeah. And the full thickness burns might require skin grafting. So that's showing you the different layers that are affected. That would be first degree, superficial, partial thickness, and full thickness, third degree over there. Okay, and then we can determine and classify burns by severity. So burns on the face, hands, and feet, and circumferential burns are the most dangerous. Why? Let's start with face. Why is a facial burn dangerous? Airway, okay. What about hands and feet? That's true, yeah. It says in your book that those are pretty severe because it can limit your mobility in the future. Like they might not be able to walk again or, whatever. And then circumferential burns, what does that mean? All the way around. Why are those dangerous? Breathing. Right, yeah. So if it's around the chest, all the way around the chest, those burns tighten up and makes it harder for that chest cavity to expand and contract and makes breathing more difficult. So the rule of nines, what is the rule of nines? Okay, yeah, the sections of the body are given percentages so we can determine how much of the body has been burned, right? There's going to be a picture on the next slide because I don't have all these numbers memorized in my head, but there's also the rule of palm, which is what? Yeah, so the patient's palm size is 1% of their body surface area. So, and then it says young children and older adults burns are more severe than middle-aged patients. It's harder for old people to recover from things like that. So here's your rule of nines. The full head is 9%, or maybe it's the front and back. I don't know. Y'all have a picture in your book, but yeah, that's the rule of nines.
So I would memorize the rule of nines for your National Registry test. I had on every one of my National Registry tests through all three sections, EMT all the way up to paramedic, I had questions about this. This is another good one. Whenever they give you that piece of paper, whenever you first walk in there and trying to jot down all the stuff you try to remember in your head that you might not remember, this is another one. Just take you draw you a little stick figure and then write your little number percentages on the little stick figure next to it so that you remember. Because there's a pretty high likelihood that you're going to get questions about this on your test.
Yeah, I don't have these memorized, but you probably should. So, yeah, this is like I don't know if they consider this an infant or a child, but there's a child's thing. They got a bigger head, so it's more percentage, right? Huh? Infant. Okay, good, cool. Yeah, and then there's your rule of palms. Palm, 1%. Whatever their palm size is, not your own palm, their palm. Okay, so burns treatments. Thermal burns, of course, we want to assess their ABCs and take care of any injuries there. With thermal burns, there could be airway injuries that present with hoarse voice, charring around the mouth or nose, and facial burns. Of course, we want to stop the burning. So if they have, singed clothes on, maybe take those off. We want to wet them down, smother them with water, and remove any clothing or jewelry. Why do we want to remove jewelry? Swelling, yeah. And then if it's a semi-solid, like grease, tar, or wax, we want to cool it down with water, but don't remove the substance. That's what it says in your book. We want to wrap it with a sterile, dry dressing and bandage that to hold it in place. We can call ALS for pain management. And then if it's burns to the eyes, again, we want to cover both eyes to kind of prevent that moving there. Chemical burns, so we want to wash away chemicals with continuous flowing water for at least 20 minutes. Depends on the chemical though, and I'm not super well versed in that either, but typically we're going to try to wash it away with continuous flowing water, apply a sterile dressing, give them shock treatment and transport. So there's continuation of chemical burns here. Mixed or strong acids and unidentified substances, we want to continue to wash with flowing water. If it's dry lime, we don't want to flush it with water first. We want to try to brush that powder off of them. Okay, carbolic acid, it doesn't mix with water. So for the first initial wash, you want to rinse with alcohol and then follow that with water. Sulfuric acid, we want to wash with water. Hydrofluoric acid, wash with water. Okay, again, I don't have all these things memorized either, but what's a resource that we could use to figure out how to treat these things? The ERG, right? It talks about chemicals, right? You could look in there. Okay, that's what I would do anyway. Okay, radiation burns. So that these can be difficult to detect without specialized monitoring equipment. Contact with the source or with a patient contaminated with radiological materials can pose a risk to your own well-being. But we might be called to care for a patient that's already been decontaminated. So if they haven't been decontaminated, we don't want to touch them. Yeah. Okay, and then electrical injuries. Good. Okay. Okay. Electrical currents, including lightning, can cause damage to the body. So there's a big list of signs and symptoms. There could be burns where the energy entered and exited the body. They could present with paralysis, muscle tenderness or twitching, respiratory difficulties and or respiratory arrest, irregular heartbeat, elevated blood pressure, fractures, and seizures. So in electrical injuries, of course, again, we want to look at their ABCs and treat any problems there. Electrical injuries can cause cardiac arrest, so we want to give that cardiac life support if it's needed. Shock treatment, C-spine precautions, and splinting of fractures if that's needed. We want to look for the entrance and the exit points. Cool the burn areas with water, dress and bandage, and transport. Okay, any questions on any of that?
So the only thing I don't think that we covered was the penetrating chest wounds. Huh? Oh, is that on Thursday? Oh. Oh. All right, never mind. I just saw all the rest of the penetrating wounds, so.
Yeah.
No.
Wow. Okay. Yeah. Cool.
So I did want to touch on real quick because our student had a really good question earlier. There in your book it says like you can use cold packs to help stop the bleeding, and then they're like keep the patient warm, right? So that kind of contradicts itself. So whenever they're talking about cold packs, that's like a very pinpoint area distally. If we're trying to keep a patient warm, we're going to talk about the trauma triad of death. So there's 3 things that helps our blood clot. So hypothermia does not help our blood clot. Cold patients do not clot well. So we want to try and keep our patients warm. And whenever you're looking through shock treatment, and even on that sheet, it says that you treat them for shock. So you keep them warm with a blanket. We have special blankets that we use. So that's a big thing. So yes, you can use cold packs, like if it's a distal extremity and you're not expecting like something major. But if you're dealing with like a major trauma, make sure that you're keeping everybody warm. Back of your truck, you should be sweating. It sucks, but it's best for the patient. So yes, that was my thing. We're going to talk about the trauma triad on Thursday and all the occlusive dressings and all that fun stuff too. So that's it. That's all I got. So,
Still Hannah's thing. So I'm just going to touch on this one more time for anybody that was not here. If you do not complete your pretest by the date in which it was assigned and supposed to be completed from here on out, I will zero it out. If you give me a heads up with plenty of time, not the day before, not the day of, there's no reason why you wait till the day before it's due to do it. But that's just a personal opinion. That's called procrastination. But if you do, that's between you and your grades. I will not extend them out. If you give me ample notice and say you're going to be out of town and you need assistance with rescheduling that, we can talk about that then. As far as the tests go, remember you have 2 weeks. If you are behind on any chapter test, you have 2 weeks from tonight to make those up. If you do not make them up, I will zero them out. If you drop below an 80, well, again, that's between you and your grades. So just keep all that in mind. And before everybody leaves, we need to clean up this room. Yes, sir. I have never used that. So they're coming out with this new injection, and we were looking at this stuff. It's still in FDA approval stages. It's still in approval stages. All right, y'all. Y'all have a good night. We'll see y'all on Thursday. But it's still in approval stages for the FDA. But essentially, it is